Hey YouTube, it's Marita and welcome to another edition of the Nurse Lounge. In this edition, I'm actually going to answer yet another subscriber's question, and she wants to know, as a new RN graduate nurse, what tips do I have for someone wanting to enter into postpartum mother-baby OB? Well, she said specifically mother-baby, to be honest with you, so I guess I'll stick with mother-baby. But what I say with these tips can be used across the board for the OB unit. So with that being said, let's jump right on in. All right. First, let me introduce myself. If you are new to my channel, my name is Dr. Marita P. I'm a registered nurse. I've been a nurse for 16 and a half years, and I am an OB/GYN, well baby nursery nurse. I'm a nurse educator. I teach at a HBCU. OB/GYN is my specialty, so that is what I teach at the university. And I am doctorally prepared, which means I'm a doctor nurse, which means I have the highest degree in nursing that you can obtain, which means I am an expert in my field. Now, with that being said, I only come to you with things that are either research-based, which means I'm telling you because it is factual, it's based on research, or I will state in the video if it's something that's strictly my opinion, which means it's not research. Sometimes it has research as a basis for it, but it's just my opinion, which means we all have one, and I can give you some valid reasons as to why it's my opinion, but it is just that. This video is not per se research-based, but it is experience-based. So this is my experience. I've been a nurse, again, for 16 and a half years. It'll be 17 years in June. June 7th, to be exact, was my first day on the floor in 2004, and we are in 2021 right now. So yes, I think I know what I'm talking about when it comes to OB nursing specifically. So let's go ahead and jump right on in. I did a video similar to this in the past. However, now that I'm teaching full-time, and I know what I'm teaching to my students, and then on top of that, with COVID going on, and I'm learning, that we're not having clinicals, at least some of the facilities are not having clinicals as they should be. And I'm sure this is going on around the United States, where you may be in clinicals, you may not have been in clinicals, you had hit and miss, things like that. So I'm going to incorporate some more tips along those lines, in addition to tips specifically for OB, in which you need to know, or what I would suggest you do when it comes to governing yourselves in working in OB specifically, but also applies to being a new nurse, period. So let's go ahead and start with, I don't have any pencil or paper. I usually write stuff down, but I didn't do this today. So we're going off the top of my head. So it's going to be kind of all over the place, but that's okay. Take some notes though. Definitely write down the things that you think is most important to you, and govern yourselves accordingly when you go to pursue your job as an OB nurse. All right. I am going to do a separate video on the different areas of OB. So they have OB/GYN, they have antepartum nurse, they have a perinatal nurse, they have a postpartum nurse, a mother-baby nurse. All those things you all think is the same thing, but they actually mean something slightly different in each one. But it also depends on the hospital. So watch for a video for that coming up soon. Okay. All right. So with that being said, the first tip I have when it comes to being or going into OB specifically is ask questions. And that's true for any part of nursing, but ask questions. If you are afraid to ask questions, then you're more likely to make more mistakes, and some mistakes you can't recover from. So remember that you are taking care of a patient, and her life, because there's only women in OB, her life and the baby's life depends upon you. Also remember, in general, that you are the last person, typically. The nurse is the last person who does anything to that patient. So no matter what the doctor says, no, in terms of orders, no matter what the pharmacist does, no matter what anybody tells you, the respiratory therapist does, when it comes down to doing interventions, 9 times out of 10 is the nurse who does the intervention. He or she is the last person who takes care of that patient before the intervention is done. Okay, so it all comes down to you. If you make a mistake because pharmacy have the wrong dose and you didn't check it, that's on you. So be mindful. Ask questions. I'm not saying criticize people. What I am saying is don't be afraid to question people. My words that I use is trust but verify. And I say that in the sense of trust but verify, meaning that me personally, I really don't trust people, especially in nursing, because people make mistakes and sometimes nurses will sabotage you on purpose. But when I say trust and verify, meaning that they may tell you that the patient's fundus is 1 below or whatever it happens to be, but you want to go verify that for yourself, because you're the one who ultimately has to document that. And you want to make sure that when you document that, you're documenting it with accuracy because you did the assessment, not because you depended on somebody else to do the assessment. So trust but verify. Ask plenty of questions. When it comes to specifically skills in the OB realm, the biggest skills that you're going to use besides your head to toe assessment skills and critical thinking skills is usually Foley's and IVs. That's the biggest things you do. Some hospitals you may have to draw blood, but most hospitals have a team phlebotomy that comes up, lab that comes up and draw your blood. So if that's the situation in your hospital, because maybe you have a small community hospital where you have to draw blood, well, you have to learn that when you get there. But for the most part, the biggest things you want to learn how to do is to start your IVs, and you want to be able to insert your Foleys. If you are a situation in which you have not had a lot of experience with that, but you feel like you need it and you may not get it on your floor, you need to talk to your nurse manager and let them know where your weaknesses are, so that you can go either a same day surgery or go to the ER or somewhere like that, work a couple of shifts while you're in orientation, while you are doing nothing but starting IVs and putting in Foleys. If you're doing those things within the 2 or 3 shifts or so, that's roughly 36 hours, 24 to 36 hours that you've been doing this, then you should be very proficient. I'm not saying an expert, but proficient at starting IVs and inserting Foleys. So that is a recommendation if you are definitely new to the unit and you have not had much experience either due to COVID in this situation or just due to the fact that your school did not, or not your school, but you didn't have the opportunity to because none of your patients either needed an IV or Foley. The next recommendation I would say is definitely be honest with your preceptor. So the person who is orienting you, be honest with him or her. 9 times out of 10, it's going to be a her and OB, but just in case, be honest with him and her about your weaknesses, about your strengths. They are going to push you. They are going to push you. If they're a good preceptor, they're going to push you. Meaning that you can't, usually you have a few months of orientation. So that's something else I want to say. Some places you have, at least when I came out, I had 4 months of orientation. So I had 2 months or 3 months during the day shift, and I believe 1 night of night shift, and then I went on my own after that. So I had 4 months total of orientation. I'm not sure what the guidelines are now, but I do know they're pushing people out much sooner than they used to back when I was in school. So with that being said, at the end of your orientation period, if you do not feel that you are comfortable to be on your own, you need to speak up and say, I need more time. Now, I will say this. You need to kind of be a quick learner, because they are looking at you to see how well you catch on, how fast you can pick up on things, because nursing is ever changing. You have to think on your feet all the time in nursing. So be mindful of that. This is not the time to be a perfectionist, okay? I've had so many students who are perfectionists and it takes them so long to complete an assessment. I'm like, child, you got 6 patients to take care of. It took you 1 hour to assess her, and you got 5 more to do. You cannot do this. Okay, so you have to be working on those skills like that. So again, if you are feel like that you are not getting enough time in orientation, you need to speak up. If your preceptor is not treating you well, which kind of happens a lot, you need to speak up to the manager. First, you need to try to work this out with the preceptor themselves. It's a chain of command. Remember that there's always a chain of command. If there's an issue with your preceptor, you need to work that out with your preceptor itself. And if she is not trying to make those changes for you to make sure that you are learning what you need to learn, then you need to go to the nurse manager and go from there. At some point in time, you got to realize, this is the hospital for you, or is it not the hospital for you? There is a learning curve. There is the truth behind nurses eat their young. That's the truth. That's the reality. I'm not excusing it. I'm not saying it's good behavior. I'm just saying it is a reality. So be prepared for that. Most nurses like going to night shift once they've been on day shift for a while, because for one, management's not there. They don't have to worry about all these extra people. Visiting hours are over, or at least over early in the shift. So you may enjoy night shift better. Just try to get through it. You understand? You may understand, or not understand, but you may enjoy night shift much better than you did day shift, which is okay. Now, your preceptor, he or she's going to train you the best of their ability. Keep in mind that you will probably get 1 patient for the first maybe week or maybe a few days, maybe a couple of days. You will do nothing but just observe the nurse in his or her day. After that, he or she's going to start adding you to do certain tasks. You may start off going around just doing vital signs for the day. After that, you may start doing vital signs, water pictures, and things like that for the day. After that, you may pass a med here or there. Eventually, they're going to give you your 1 whole patient that you're going to have to take care of during the day. They will increasingly add to it. Now, if you're on a postpartum unit, it's just moms and GYN surgeries. If it's couplet care, you're going to have a couplet, a mom and a baby, okay? So they may give you just the mom one day, just the baby the next day, and the next time you get the whole couplet. So then you do one whole couplet, and you do that for a couple of days. Then after that, they're going to go ahead and give you two couplets. They're going to eventually work you up to your full load. Expect that. You will be overwhelmed. Expect that. They should be helping you, but they may, what I always do, to be honest with you, I don't want you to feel like you're drowning per se, but I do want you to feel it. This is me personally. I want you to feel it. Meaning that you feel like the water's right here. So if you were in a pool and you feel like you're drowning, the water's here. Your head is not underwater, but you can feel it. I'm that kind of nurse because I want you to feel it. I want you to know what your job is going to be. If no one's going to be there to pick you up every single time, they're just not. Why? Because they have their own patient load, for one. And two, some people just mean. They're just not going to help you. Be ready for that. After that, you need to be organized. So we talked about the patient load. We talked about getting worked up. You need to be organized. When you first start your job as a OB nurse or a mother baby nurse or any unit that you go on, you need to bring you in a notebook. Some type of notebook that you can write down everything in, whether it be codes to the doors, whether it be policies and procedures that you think you're going to forget to do, vital sign routines. Is it 8, 12, 4, 10, 2, 6? What time is it? Twice a day, 3 times a day? What that stuff is, you need to have a book that you keep up with, that you write everything down in. And then once you do that, it becomes muscle memory. You just remember it after a while because you do it over and over and over. It's repetition. So when that happens, you don't need your book anymore. But the one thing you don't want to do is keep asking the same exact question over and over and over again. Because you're going to be like, okay, are you not paying attention to what I'm saying? Or are you not writing this information down? A preceptor will become annoyed with that. Do not do that. I cannot stand when people ask me the same question, because that means to me it's not that important to you. So you think you're going to waste my time by asking me again because you don't want to have to remember it? No, you need to remember it. So go ahead and write it in a book. Get you a little notebook. Write down all those things, your codes, your password. You know you don't remember your password. Remind you, maybe put it in a way in which you would know what it means versus if somebody found your book, they wouldn't know what your password is. But you're going to put in all those different things like that. Passwords, codes to the doors, vital signs, schedules, how to do certain things. This is certain doctor quirks that you may find out about. When is the cafeteria open for breakfast, lunch, and supper? What are your true numbers to, if you need to call a code, or if those things will be on your badge too. Typically some of those things like call code or whatever, but they may not be. Every hospital is not the same when it comes to that. So you want to be mindful of those types of things. So I have my badge right here. My old badge, because I don't work in the hospital currently, but my badge looks like this. Okay. So I'm not going to put the hospital, but the badge looks like this right here. It has my picture on here, my name, and that I'm an RN, that I worked on postpartum. So let me show y'all that. So my name, RN postpartum. As you see, it has a pink border. It has a pink border because of the fact that we are on a secure lockdown unit. So basically you need to understand that if we're on a secure lockdown unit, that people who do not have this color, or whatever your floor's color or code or happens to be, to let other people know who works on that floor. This is how we know on our floor that who works on our floor and who should have access to the babies and the moms and who should not. Our floor is a lockdown unit, meaning somebody has to pick up the phone and say, I'm here to see patient Miss such and such. And we make sure they verify that that patient is actually there and all the other stuff, and they're not confidential. And then after that, we let them in. We tell our patients, the patient needs to have, the nurses who come get your baby need to have, at our facility, this pink border. Again, every hospital may have a certain way of doing things in which it may not be a pink border, but it's some other type of clue or code or something they have to let you know that you are supposed to be on that floor. On our hospital floor, the rest of the nurses who do not have access or do not need access to our floor, their badge will not work on the elevator to get dropped off on our floor. So for instance, when I come on the elevator and I'll say I work on this floor, well, the nurses who don't work on that floor cannot push that floor. Their badge will not work on that floor. So I have to go put my badge there and then push the floor that I need to go to, and then it will actually open at that point in time. So that's something to keep in mind too. It's a secure unit. Be ready for that. Most places are a secure unit. Be ready for that. I've still seen some hospitals, well, I don't know why, because people do steal babies, that is not secure, but be mindful it is a secure unit. So you're going to have your badge, okay? On the back of my badge, as you can see right here, we have all our emergency codes, what the different colors mean. So be mindful, you'll have these codes as well at your facility. Now, I mean, not that you can read it anyway, but don't go by my colors, because my colors mean something for my facility, where your colors may mean something for your facility. Code pink typically is always an infant abduction or baby abduction or pediatric abduction. So that's pretty almost universal, such as code red is almost universal and code blue is universal. But some of these other colors right here can be different depending on the hospital that you work for. So you'll have that on your badge. For us, we have blood monitoring. So a little cheat sheet for that. So this, if you don't have something like this may be something that you want to put in that little book that I was talking about. A little cheat sheet for things like this. Then we have what's called an S-bar. So when we call the physician, what that means, what an S-bar means, what we need to be asking, again, it's another cheat sheet. So if you don't have one of these on your badge, which you may not, every hospital does not do this, then you want to have it in your little notebook that we just talked about. And then for us, we have, this is a sepsis screening criteria that we have on our badges in terms of what defines sepsis. You may not have nothing like this. If you happen to work in OB and you may not typically need a sepsis screening criteria, because if you're septic, you're not going to be on OB floor. However, because we do have GYN patients on our floor, we do have to know how this works. And of course, the last thing is the fact that I'm a registered nurse. This is how we identify registered nurses from other people, okay? That plus our uniform. Our uniform is navy blue. Navy blue for us means that we are registered nurses, but every hospital has their way of doing that. So we talked about the little notebook. Have your notebook, okay? Ask questions. If you have issues with preceptor, report it. Be ready to work. Have your notebook. What else? Be ready to work. If you are lazy, and this is true for all nursing, if you are lazy, keep in mind that you are in what we call a probationary period. So even though you were just hired, you're in a probationary period, just like with any other job. That is a 90-day window for your employer to see if you gonna meet their needs or not. And if not, they will let you go, okay? Also, this is also a period of time to see if this is really what you want to do, or if you feel like this meets the needs that you want to have as a nurse. And if not, then you need to find another job. So don't think because you have the job that they have to keep you. No, guess what? Nurses come a dime a dozen. You have people graduating from all kinds of schools, different, at least 2-3 times a year. Nurses are coming out of nursing school. With that being said, what you won't do because you're too lazy, somebody else will do. So if you're not someone who is willing to work, your preceptor will report that. And if she reports that you are too lazy to work, believe you me, they will have you out of there so quick, okay? Now, let's go ahead and talk about the thing that we don't want to talk about, but nurse bullying, harassment, things like that. As the new nurse, you 9.9 times out of 10 will feel the pressure of being the new nurse, the new nurse on the block, the new nurse in the unit, whatever. Nurses, because we're mostly women, are very cliquish. We're very high schoolish, in my opinion. Not all of us, but a lot of us are. We're very catty. We are jealous people. If you come in, you're young, you're beautiful, whatever it happens to be, and they're older and they feel like you're going to replace them, they don't like it and they treat you some kind of way. Also, hurt people hurt people. What that basically means is if they've been hurt at some point in their career or their lives, they just went through some things sometimes and they have not healed from that, they will treat you the same way. I'm not condoning it. I'm warning you. Be ready for that. I spent my whole first year crying, and the nurses I've talked to, even as recent, spend their first year crying. That is just the reality of being a nurse coming out of school. It's rough. I'm not trying to deter you from nursing. I'm just trying to paint you your reality, how it's going to be. And as time goes on, you will grow your tough skin, so to speak. And when you grow your tough skin, then you will be able at that point to see that, okay, you know what? I'm not here to make friends. I'm not here to hang out with these people on the weekends. With that being said, do you want to make friends? Or, okay, do you want to make friends? No. No, you don't. You're not there to make friends. You're there to do a job, take care of patients. If you happen to make friends, then that's wonderful. But is that your goal? No. Be mindful of that. You want to meet people who are going to do, who you could be friends with and hang out with. You want to meet fellow nurses who you can just kind of bond with. That's not a problem to want that, but don't need it. If she comes along, whoever she happens to be, and they come along and be a good nurse, then great. Now, with that being said, I want to go ahead and talk specifically to my minority nurses, and that OB specifically, because that's what the person asked about, mother baby specifically. when you're not only a minority, but you're a minority. So you're a minority in terms of skin tone. Okay. So you're usually going to be, well, just minority, whether it be black or whatever. You're a minority, unless again, you live in a populated area that is mostly ethnic minority. So you live in Atlanta, Philly, Chicago, Detroit, places like that. If that's where you live and it's heavily populated with minorities, this is not who I'm not talking about you. I'm talking about the rest of us who live in areas in which it is not heavily populated with minorities, ethnic minorities. And in the OB unit specifically, you're going to be even less of a less prevalent, less seen than if you worked on a med surg floor. By design or by default, med surg is where they want all of us to go. However that works for you, that's fine. However, you will not see many minorities in OB typically. Again, I worked for a unit that had maybe 100 nurses, and I'm just giving you a really rough estimate, 100 nurses. And let's say 100 both day shift and night shift. If not 100, maybe 80 to 100 nurses, day shift and night shift for 3 units, or for 4 units actually. So we had postpartum, we had L&D, we had what do we have? Nursery and NICU. The nursery and NICU nurses actually worked. They rotated between the 2 units, but there is still 4 units technically. So between those 4 units, day shift and night shift, let's just say we had 100 nurses total. Out of 100 nurses, only about 5 of us were black. That's it. So you're not going to be amongst a whole lot of people who look like you. So therefore, don't expect it. You're going to feel like an outcast sometimes. Expect that. Also, just know that sometimes we do it to ourselves. We hurt our own people. Expect that. So that is not good, but that is the reality. So sometimes for some reason as minorities, we think it's competition and it's a challenge and we're kind of like we want to compete against somebody. We ain't got to do all that. We ain't got to do all that at all. However, that's what people do sometimes. So be mindful and be prepared for that. Will you have a harder time in OB because you're a minority? Maybe. Maybe. It just depends. It just depends on who the management is and what he or she, usually a she, what they tolerate and put up with. Also, I want you to be mindful of, this has nothing to do with being minority, switching gears here. In terms of leadership, you will often see that how the floor is ran or behaves is based on the leadership. If the leadership is bad, the floor is going to be bad. The unit's going to be bad. The nurses are going to be bad for the most part. Because guess what happens? If you have nurses who are always doing the wrong thing and the leader is either lackadaisical in her approach, she's not doing much to change anything, or she's a part of that same narrative doing the exact same nonsense. If that is the case, then your whole team is going to be corrupt. It starts from the top down. So if you want to know if you're on a good unit or not, what you need to do is look at the leadership. Look at the management. When you have a problem and you go to her about it, is it handled? And if it's handled, how soon and why? Not why, how? If she's okay, I understand it, but nothing has changed, a good portion of the time, they are friends with the person that is mistreating you. That's the reality. They're very close friends with the person who's mistreating you. You think they're going to reprimand them? No, they're not. So be mindful of those types of things. If you want to know how good your floor is, be looking at how good your leadership is. And I cannot stress that enough. Now, I will say this. Every hospital has its problems. Every unit has its problems. So to be in the habit of going from hospital to hospital to hospital is not good in terms of like less than a year. You need to try to stay, unless they're jeopardizing your license or your safety, you need to try to stay at the hospital for at least a year before you move on to the next facility. Just saying. Now, if your license is being jeopardized or your safety is being jeopardized, I would say, yes, go ahead and make a move. There's nothing wrong with that. But just know there's going to be something everywhere you go. Whether it be your staffing issues, whether it be your acuity issues, whether it be your nurse-patient ratios, whether it be just the ill treatment or poor treatment of the nurses towards you, whether it be the demands that they have that's beyond what you do as a nurse. And that's one more thing before we end this. As a nurse, I've discovered for the past 15 years, what I have to do as a nurse has extended and extended and extended. I honestly probably spend about 15 minutes assessing my patient. So for me, it takes me about 15 to 20 minutes to assess the average patient. It takes me about 30 to 40 minutes to chart on that same patient. That's just how it is. You will not get to spend as much time with your patient as you would like to. That is unrealistic to expect that. Now, if you only have 1 or 2 patients, maybe so. But if you have a full load, which is typically 6 postpartum patients, 3 to 4 couplets, which is mean 3 to 4 moms and babies, which is 8 patients, or 6 to 8 patients, you will not have time to do that. You're going to spend about 20 minutes once you get good per patient to pass meds, do an assessment, and do vital signs, depending on the situation going on with that mom and or baby, or however your floor is. Be mindful of that. It just takes time to learn how to do that. One last thing, the things that you need to work on for sure, and this may be the most important of them all, is time management, prioritization, organization, being self-directed, critically thinking. Those are the things that you need to focus on. Again, not in the same order, but time management basically means that you're going to work on how fast and how efficient that you do the job that you need to do. Again, it takes me only about 15 to 20 minutes per patient to do vital signs, meds, and the assessment. That's not including charting. That's just the vital signs, meds, and the assessment per patient. Now, some patients may take a little longer because they're a fresh C-section, or they just have other issues that takes longer. Some of them may take shorter amount of times because maybe they don't have as many meds to do. But on average, you may do 15 to 20 minutes per patient. With that being said, when it comes to organization, get organized. Take the time at the beginning of your shift to figure out each patient and what you need to do for each patient. Write that stuff down. Okay, for this particular patient in room 3300, I need to do all of this for the day on that patient. Write it all down. Write down all your medications you have to give, what times you have to give for that patient that day. Do that for all your patients. Same thing for baby if you have baby. I only did a postpartum. We did not do couplet care at our facility, so I'm only speaking of moms, but the same thing is true for moms and babies. You also want to be mindful if they are day 1 or day 2 of whatever they had, a vaginal delivery or C-section. Be mindful of those things. Where were they at with all that? Okay? So when that's being said, when it comes to day 2, day 3 patients, they're more than likely going home. What types of things need to be done for them? Discharge teaching, and who does that? That goes in your book. Who does the discharge teaching in your hospital? We ourselves did it at our facility, but some facilities have a designated person who does the discharge teaching. You need to write that in your little book as well. So organization means all that. Figuring out what you need to do for the day for each patient, figuring out your routine versus vital signs are done at this time, how often you do vital signs per patient. Figure all that out, get organized. So time management and then organization. Prioritization basically means which one do I do first, which is most important. Is it more important for me to check my orders on every single patient or to go see that patient who they just said was bleeding? Go check your patient. You don't be checking on orders and stuff like that. You don't have time to do all that. I do check my orders at the beginning of the shift, but once you know your doctor, there's very few things that change about your doctor depending on your patient situation. If it's the exact same patient who has the exact same vaginal delivery as everybody else, the exact same C-section of everybody else, your doctor's order is going to be pretty much the same, with the exception if they have hypertension, they have diabetes, they may have to add medications or whatever they have to do for that. You have to go look that up. However, I spend time looking up my medications. Overall, look at orders. I do look at a few labs if we had some for that patient. Every patient doesn't have labs in OB. Some hospitals or some doctors order labs on everybody. You have a doctor who don't order labs on nobody. You just have to figure that out when time goes on. But what's the priority? That patient wants a Sprite. That patient needs to go to the bathroom. The Sprite can wait. And matter of fact, as a registered nurse, you can delegate that to somebody else. So say, hey, are you busy at the moment? Can you take the Sprite to room for me? I need to go get my patient up for just a minute. And if you don't have nobody to do it, guess what you need to do? Go get your patient up. And after that, go take your Sprite to your patient. Prioritize. Get in the habit of doing that. The next thing, self-direction, self-directed learning, meaning that you are not going to ask 50,001 questions. I did say at the very beginning to ask questions, yes, but don't be asking things that you can look up for yourself. If you want to know, let's see, which is the reason why you need just your book, that little book I told you about. Just get your little notebook and start writing notes in there. Self-directed learning means I'm going to go look for the answer for myself. And if I can't find it, then I'll come and ask, okay? So get familiar with doing those types of things. So self-directed, let's see an example of that. My student asked me, what does SVD mean? Well, I know they had it in class, so they need to just look it up. SVD means spontaneous vaginal delivery. You need to go look some things up, okay? And then verify with whoever preceptor that this is what this means. Be self-directed. They're going to be appreciative of you for doing things like that than to ask them 50,001 questions that you could have looked up on your own. Now, if it's an emergency situation, we don't have time to look nothing up. Ask the question. What does this mean? What do I need to do? Ask the question. And then I said critical thinking. Critical thinking comes with time. Okay. Critical thinking comes with time. So when it comes to that, you all need to be mindful that it just comes with time. And you need to work on those critical thinking skills. If you are finishing your program, hopefully you have established some minimal critical thinking skills in order to even be complete with your nursing program and to start as a new nurse. And I think I want to say that's pretty much it. No, that's not it. One more thing. This video can go on and on and on, but to keep it under 40 minutes. One more thing is when you have downtime. Downtime means that you have taken care of your patients. You have documented and charted everything you need to chart on them. You did your patient rounds. Everybody's is fed. They have water. They've had their medications. They have the vital signs done. Everything's done. You have a little downtime. You need to go to the intranet, and start looking up policies and procedures for your floor. Specifically for your floor. Hospital as well, but for your floor specifically. If they don't have it on the intranet, which they should, they will have a binder of some sort on your unit that says policies and procedures, nursing policies or procedures, whatever happens to be. So if you want to know how to hang blood, what's the policy on that? Go find it and look through that. Start learning the policies and procedures so when things come up, when you got to do it, you ain't got to look it up then. So you got to hang your first blood at this point in time. You should have already been familiarized with what the policy is at your hospital regarding blood administration. That's just an example. So anyway, this video is long enough. Hopefully this give you a few tips and some insight. If you want more, we can actually start that when we do our live Q&A in the next couple of months. But feel free to post any questions you may have, a video you want me to do. Also, speaking of live Q&A, we are about 85 subscribers away from having 2K. 2K was my goal. I said once I got to 2K, I would start coming on here live and talking to you about nursing questions that you may have, okay? So with that being said, nursing questions that you may have about my journey, about anybody's journey, about whatever happens to be, that's what I'm here for. We will start that when I get to 2K. I do need to finish my semester for the most part, so I will start that. Once I hit 2K, I will start that actually at the end-ish of May, end-ish of April, beginning of May. But again, the goal is 2K. So I need you to like, comment, share, subscribe on this channel so that we can get to 2K so I can help either you or people that you may know who have questions about nursing. If nothing else, then that is it. And I thank you for watching this video. And until the next time, take care. Bye-bye.